So this patient's coming in for removal of a lesion that's been growing on her left upper arm for how long now?
Over 15 years.
Decades. So this is mobile. It's tenting a little bit. Ultrasound seems consistent with the cyst. So we've done a circumferential block through here with lidocaine. We're working with Dr. Laser again today, but he's got some laryngitis, so we'll be asking minimum questions. So why am I dissecting in this plane? What are those lines that I follow?
Langer's lines.
Yeah, listen to that husky voice. It's fantastic. So this is all frozen through here. And no pain when I do that?
Nope.
So this is an uninfected field, so we should have excellent anesthesia. So if any point in time again, and we had this conversation before, you feel anything other than just pressure, let me know and we just add some extra in.
Okay.
All right? So and why an elliptical incision versus a linear incision? What are the pros and cons of?
Well, in a tented lesion like this, you can approximate the tissues easier because you're going to be removing some.
Yeah,
it's
so
hard
there's.
to draw it back together with just a linear.
Well, there's an argument to be
without
had.
dog-earing.
You're gonna, yeah, exactly. You're gonna have redundant tissue, right? Because this is swollen because she's developed it like that.
So you just want to get like that at the top where that epidermis is.
Yeah. So
That's good.
I just
And
want
we
to
don't wanna
dissect
keep
this
it
down.
in.
No. So once I've gotten a little incision here. So we just run the risk of rupturing the membrane. So again, not the end of the world, but generally I want to work with as clean a field as possible and
Right.
dissect it down so then we can know that we've actually dissected out the actual membrane. So here, I'll just start taking this. And now the angle which I dissected down, where I'm holding my blade, this is where those purple marks will we
Yeah.
delineate. So I've got the end of it is through here. So if I'm too acute an angle, I'm going to hit the membrane and just going to mess you up the field. You dab that for me, Rada? So this is essentially, I just want to be extending this slowly and consistently. And we'll do the ends last because that should be close, and that's why we always have them close to the margin, so that I can dissect down quicker.
Yeah, it's probably the second biggest epidermal cyst I've seen.
Oh, is it?
Yeah.
Oddly enough, it's not the second biggest I've seen. But this is a good size.
Yeah.
And all that, it doesn't change much in terms of what you're going about. You just want to be dissecting down. It can sometimes make an issue with, so I want to maintain the capsule as long as possible. And ideally, if I can take it out intact, and I don't do that from an ego perspective, it's done simply because if it's intact, then we know it's entirely out. So if it ruptures, it ruptures. But in this particular case, when you're dealing with medium to larger size ones, sometimes you actually need to rupture them just because getting it outside the incision becomes complicated.
Right.
But I would tell you that's fewer and far between. Typically you can dissect it down, and the reality is it might just be more a function of taking more time.
Okay, pause. I know you're gonna love this video. If you want more, over on the Patreon today, we remove a pilar cyst from this man's scalp. Here's a clip of that. As always, the link's in the caption. Enjoy the rest of the video.
Which sometimes people viewing this stuff can get frustrated with, but you're literally talking about the difference of a few minutes,
Right.
you know, so it's not a big issue from that perspective. Certainly if you were talking about whatever you were doing, if it was taking like long amounts of time extra, then it would be a bigger issue for us. You're comfortable?
Yep.
I'm going to shift around here so it's a little faster.
Did you get to the margin there like you felt?
Not quite. Do you want to shift this just over for me? Shift it. Be careful. And this is always the hardest part of the procedure, to be quite honest. It's just about, depending on how tented it is and how much pressure it's there, you're going to be dealing with superficial areas and getting a nice line on it so you can actually open it back up. That's actually better out if I can reach through here. I'm compromising my light a little bit, but that's okay. So you can appreciate there's back pressure here. See how it's
Yeah.
pushing itself out a little bit more? And you're comfortable?
Yep.
So that element where I'm seeing back pressure will also dictate the angle of my blade. Because if I'm picking up that there's a lot of pressure that's there, then I know it's pretty superficial.
Right.
I just want to be a little bit more careful in terms of how I operate.
Just based off of feeling this one, it feels pretty tense, but it
Yeah,
doesn't feel like
yeah.
it would like explode, would it? Or is that not
No,
possible?
yeah, no, it could. So it's certainly there's a lot of back pressure that's there. Do we have the?
cleanse.
Cleanse the
Yeah, I know.
scissors. So I'll use the dull scissors in a second just to sort of see if I can dissect that down a bit more. And then I'm going to do the ends. Here, I'll do the end first here. So this, I just grab the tip and then I'll just cut that along that line. The retractors, yeah, thank you. Oh, did you say I
Careful
apologize?
because
I didn't
bottom
hear.
is
I was
sharp.
thinking, I just wasn't saying it. I'll let you put that in there.
Now I feel like I'm back in the OR.
Yeah.
Just need someone yelling at me a little more. Yeah, if you hit me in the head with that, then it'll be fully in the
Yeah,
OR.
fully in the OR.
Yeah.
Somebody telling you you're doing that wrong, and you say, "I'm not doing anything." Well,
Yeah.
you're doing it wrong.
Whatever, you're breathing wrong.
Yeah, this is actually pretty taut. So I'm going to come back around to your side and I'll dissect this side out. So same thing here. So at the edge, I'm just going to dissect around that. So I just swing the blade. So and again, what I'm looking for here is we're trying to dissect down to hypodermis. So this is where I actually want to see if I'm getting to the right level, that we're getting a fatty layer that's there. See that here, it's starting.
Yeah.
Because that's what I want to be seeing, so I can actually get back around behind it and then start dissecting in the other plane.
So we know we're deep to it on this corner.
Yeah, on that corner we are. Just retract that there for me.
Is that also subcutaneous tissue?
Yeah, that is there. It's just over top of it. So whether we're under it or not will be the issue. I'm just going to grab the... So see all that? Like that cyst is right there. Just retract that for me there. I'm going to come back around to your side. I'll switch with you. Still comfortable?
Yeah.
Not feeling anything?
Nope.
There. So what I'm doing here. Just pull that up for me there a little bit. So you can see that it's shifting now.
Oh, yeah.
So now this issue is going to be, can I get back around that edge?
And underneath it.
Yeah, and that's where we'll have to make a decision. So this is where, again, you can get frustrated with this and sort of say, well, let's just incise into the actual capsule. I'd always discourage you from doing that because, again, if we just take our time and we just shift this around, if the capsule ruptures, then it ruptures. It's not a big issue. But if we just take more time with it, I'll just shift this way for you. Push up here. This will slowly release itself, and we'll see what we're dealing with. And come back around to your side. So this is certainly where the capsule, where it extends deeper on this side. Pull this up here. You're still comfortable?
Yep.
Just shift it that way. So we'll see what it looks like. Alright.
Pretty mobile now.
It is. I'm just debating where I'm gonna. I think I'm gonna do it from this side. So I'm gonna switch back one more time. So what I'm debating is just which side seems less adherent, and where I'll have more success just dissecting this away. And I think it's gonna be from this side.
Oh, I'm feeling something.
Feel that?
Not that it super hurts, but I definitely
Feel something?
Something, yeah.
Yeah, we're at the back end. So I'm going to add some more freezing for you. And this is always where the back end, where you wonder whether there's perfect anesthesia.
So, for injecting, would you just inject back on the superficial line up here?
No, the problem is it's deep. With these bigger ones, this is where you'll notice it, is right at the back end, because we can't quite get behind it as much as we'd like. So I think I'll have to come to your side again to inject that. Does that sting at all what I'm doing there?
No.
Is that hurting a bit?
No. It's okay. Sorry. At least my feet aren't moving this time like the last time.
It's almost done.
Let's shift this way. That's probably where you sit. Not hurting?
No.
Just relax for a second.
Henry's not going down without a fight.
Yeah. Is he still in one piece?
Yeah,
Yeah, actually.
Oh,
Mhm.
That's cool.
it is.
Well, this is just the difference. Like I said, you could easily have ruptured this and again, maybe saved yourself a couple of minutes of time. But now we'll have no doubt. See how I'm right behind it now?
Yeah. Now it's easy.
Yeah, now it's just a function of, and this is why I'm saying to you, if you just take your time with it, it's certainly a bit of a headache. See how those adhesions, see those, they're actually, see this is what adhesions look like behind a cyst. This is what we're just breaking down here. And that is it. So bring this, just put a blue drape over top of her there, if you don't mind. I think I'm gonna get another one because I don't want to. The patient's brought an assistant with her today, wants to take a picture, so we're gonna let her take a picture of it.
Oh, yay.
So this is, Henry, this is the tissue we took out there. That's the, so you get a feel for how big that was. So what would we expect when we cut into this?
Keratin.
Yeah, so what color would that be?
Depends on whether or not it's oxidized, but
Yeah.
yellow, gray.
Take pictures of him. Oh.
Some serous fluid.
Yeah.
Some purulent serous fluid.
It's liquid?
And you can see that. So that's,
I
it's
thought it was
oxidized, yeah,
liquid.
it's grayish. That's inflamed care. And this is why, again, we try to avoid, because that obviously messes up your field a lot, if that opens up while you're doing it. Not, again, the end of the world. It's certainly possible to work with it. But now there's no doubt that we know it's fully removed. So here, I'm just going to cauterize a couple spots, but this is...
You want to rinse it, flush it?
Yeah, we're going to rinse it too. So again, irrigating, the only real error I tell you medically, so if you're doing these, Dr. Laser, yeah, I know, I just have trouble with that every time.
Dr. Macy great today, actually.
Oh yeah, because of the voice, yeah, very nice. So it's really only the very posterior wall that you want to make sure is not having an active bleed. Because any area, is that hurting?
I don't know if it is.
You
Yeah.
felt that a little bit?
Yeah.
Yeah, there's a different type of pain receptor that might feel the actual cautery. So, and we don't need much there, so I'll leave that alone. But it's the back wall that we want to make sure doesn't have a brisk bleed, because that's not going to be caught by any sutures, and then she'll have a hematoma for sure. And these larger ones, that's the risk that you'll run into. Infection usually isn't as big an issue for us. Can I have some irrigation?
Oh, you got 3
It's
right
over
here.
there.
Oh, it's there, okay. Here, just hold that on that side for me. So this is not as relevant to as if it was infected and it had ruptured inside, that you want to make sure you definitely clean it out. But I get in the habit. It's never a bad idea to irrigate.
You want to use the internal staples?
Yeah, please. Yeah. Good.
And then it's definitely dermal sutures, right?
Yes, it does for sure. So we just want to take a look at this and see that we have to clean that up a little bit. No, it should be pretty clean. So you can see here, though, how, especially when you appreciate after the fact how big that was, that if we hadn't taken skin out, you'd have redundant skin overlapping. So this is. So for this one here, you need your Adson pickup, so you have the teeth on it. So again, you're going super deep to superficial. The closer I am to the dermal epidermal junction, the tighter the stitch will be. And while that becomes really relevant when you're doing a lot of plastics procedures, for this, it's more about just adding a strength layer. So if it was slightly off, the only difference is this would gape a little bit, but we don't care so much because we're adding a layer on top of this, which will close this up. So realistically, we just want this to help carry all the weight. So that's there. So this one you tie like a normal knot, so one loop, pick it up and close. And you don't pull too hard or you'll rupture the suture material, and then cut right on top of the knot. Perfect. So again, if I was, 3 probably. So if I was not as tight there, this would be opening more, which again wouldn't be the end of the world. But you want it to be holding the actual strength of the actual incision. So one loop, grab, pull. And you're still comfortable?
Yep.
Nice. So what would you do if while we were doing this, we were noticing that blood was welling up continuously?
Find where it's waiting from.
Yeah, exactly. It's all basic principles, right? So never be afraid. Like if she was just pooling, then clearly there's blood behind it. So we would just cut these stitches out, find that active bleed, and either tie it off or cauterize it. But what you don't want to do is just be like, oh, let's close it quickly and put pressure on it. You can do that sometimes if it's a scalp, it's very superficial, because again, the pressure you put on will tamponade it. But if you're dealing with an actual deeper, bigger incision like this one, you'll get yourself into trouble. For sure you're going to have a hematoma, and those will complicate. I mean, you can have a hematoma develop anyway. Do you remember the rates of hematoma? Just cut on that.
They're pretty low, right?
Yeah.
1
They
or
quote
2%?
1 to 2%, and I would tell you, anybody who does these procedures regularly, me included, it would be much less than that. You know, again, in my career, I can remember maybe 3 distinct significant hematomas. You know, and that's doing thousands of these. So again, here we have good apposition of this incision line, but if it was gaping a bit, we would be bringing this together with our interrupted stitches. So don't be, if this was open 2 or 3 times as much, so let's say it was gaping a few millimeters, you shouldn't be dissuaded, because again, at least it's holding the strength. So here's our V, and then your interrupted stitch would just bring that together. But when it is this close, this should be under no tension, and you're just essentially opposing the basement membranes. And you're still comfortable?
Yep.
See, it's caught on my instrument, so I have to just release that. Just let it go, pull it apart, and just do it again. So again, see how that's laying like that? If I do it like this, that's the improper way. So this just makes sure that you have even pressure across the incision, which will lead to better surgical results at the end of the day. So you have less buckling, more direct apposition of the basement membrane, like that kind of thing. So here's my V, 3 loops. Hold this just so I'm not losing so much thread. Hold that flat, and that should lay just like that. I'll do this one and the next one, then I'll let you do the rest. Do you want to get another cartridge, Rada? So here when I'm putting it in, it'll look like I'm going in at this angle, but you always are flipping it quickly and going in at 90 degrees, and then once you're in, then you shift it. You just do it quickly enough that it looks like you're going at an angle. So again, won't be a problem for her because she has nice normal skin, but any significant laborer, male or female, and you'll see it worsening in big males, they can have really, really thick skin, and you'll bend your needle, even if you do it the proper way. But if you don't put it at 90 degrees, you won't really get it through their skin at all. You want to do it from that side or this side?
I think we do it from this side. Or I can go with the other side.
No, your choice. I don't know, whatever you're comfortable with.
Once maybe better at that side.
Once you're stitching, you're the boss, so you get to.
Oh really?
Yep.
You're both fired.
Exactly.
I did nothing.
Yes.
That was Rada.
But you want to fire them after you're done the job. So they just a point of contention moving forward. Finish it,
When
then
I have
fire,
the stitch,
then fire your
when I
shot.
become the boss.
You coming to this side? So
Yeah.
for all that, you're coming to this
Yeah.
side. Okay. Very good.
He was confused because she told him to.
We're almost done.
Yep. Okay.
Yeah, so that's just right. Yep, position's good. And that was good, so you just re-angled it. So again, same issue will happen there. I'll have lots of young residents whose angle's completely off and they feel committed to it. They don't want to admit that they could just reposition it. At least you acknowledge it's my thread you're wasting, so it's good. So it doesn't matter in these cases, right? Because you can look at this and how many stitches you're going to have to put in, 2 or 3, so you have extra thread. It's not a big issue. But if this was your
Just
office,
starting.
yeah, then you just want to be efficient with the threads.
Just have a lot of loading up another cartridge.
You do 1 stitch per cartridge. Yeah, just make sure you triple click, or else it'll slip on you. Lying flat. Nice. And what's good is you're not putting, you just want them to close together. If you're knotting really, really hard, you'll buckle the skin. And again, that just makes the healing result a little bit less ideal. Good. Almost good. Very good. So there's our incision line. So what do we think? Do we like the incision line? What about corners? This is always a problem. Dog ear. Was there any significant dog earring there?
Just maybe up there, just very
Like
very
just touch
minor.
amounts, right? So this amount won't, this will heal out perfectly for her. And that's more a function of our incision, right? So as long as that was done properly, that should fall nicely. So that looks quite good. So we'll just see her back again in 10, 14 days, and then we'll be